Okay. Good morning, Bernhard. How are you?
Quite fine, thank you.
That's really good. So, where are you joining us from this morning, Bernhard?
I'm here in my office, in my private practice here in Graz, Austria,
Oh,
just
fantastic.
between my clinical work today. It's a very nice, lovely day here in Austria at the moment.
Oh,
And yeah, I'm happy to join you with these live sessions today.
yeah. Oh, fantastic. Well, it's not very nice here. It's completely cloudy in North Yorkshire. So, it's always the way. You always get better weather on the continent, don't you? Amazing. Okay, so we're going to kick off.
Yeah,
So, a very warm welcome to this NOI Group clinical discussion. For anybody that hasn't joined us before, my name is Joanna Taylor and I am Director of NOI Group Europe. And I am joined this morning by Dr. Bernhard Taxer, a physiotherapist with over 20 years of clinical experience in neuro, musculoskeletal, and neuropathic pain syndromes. Bernhard is a NOI Group instructor and brings both deep clinical expertise and a commitment to cutting edge pain science. Bernhard, welcome. It's great to have you here. Thanks for joining me.
thanks for the invitation, Joanna.
Could you tell us a little bit about what you are currently doing professionally, just to give people a sense of what your day or your week might look like at the moment?
Yeah, yeah. At the moment, I am part-time working in a private practice here in Graz, Austria,
Hmm.
and next to teaching and universities, and also for NOI and another concept that mainly focuses here on craniofacial topics. It's called the Crafter concept. I'm also doing research in Salzburg at the Medical University in Salzburg.
Okay.
And my research field there is mainly on migraine headaches, chronic migraine headaches. But we are also developing a nice pain model at the moment. So the pain field is also in research a great big topic for me at the moment.
Okay. You're doing quite a few things then.
Yeah, maybe
Busy.
sometimes a little bit too lot, too much.
Yeah,
Yeah,
yeah, I get that completely.
yeah.
Okay, so just a couple of quick housekeeping things before we get stuck in. Bernard and I are going to be talking for about 30 minutes. If you have any questions, please drop them in the chat, or if you're watching on catch up, please do put them in the comments underneath, and we will get back to those. The recording of this session is available on our clinical discussion YouTube channel, and I'll drop the link to that into the show notes as well. So please do like, subscribe, and share, and then you'll be notified of any new videos when they are uploaded. So, Bernard, let's get going. We've got some brilliant questions to work through today. The first one is, what are neurodynamics?
Um, Historically, we are dealing with neurodynamics in the whole medical and physiotherapeutical field quite a long time now, and great names like James Syriacs and of course Freddy Kaltenborn and all those manual therapy authorities use that since many years.
Mm-hmm.
And originally, it was mainly focused on the biomechanics of nerves and the idea that biomechanics also work in the field of nerves. When we think about the work of Alfred Breek, he was from the Norwegian region, and the idea was that originally that the stretching of nerves, the mobilization of nerves leads to better outcome with our patients. Yeah. So this is quite an old-fashioned idea, but for many years there was research on it mainly on a biomechanical way. And
Yeah.
neurodynamics actually includes the idea of our dynamic nervous system that it is connected, of course, with nerve cells on the one hand and with soft tissue on the other hand, and that it is we call it neurexis. Yeah, everything is connected through
Mm-hmm.
nerves, and this idea of treating nerves is not new. Yeah, this is quite an old idea, but the idea of how it works and how it might work also biomechanically and neurophysiologically is a more new approach in the field of physiotherapy. Yeah.
Okay, so today's session was going beyond just stretching
Yeah.
nerves in treatment.
Yeah.
And what what are we actually assessing with neurodynamics?
Yeah. I think this is a very important question. Actually, we are assessing the mechanosensitivity of the soft tissue of the nerves,
Mm,
of peripheral nerves. And I like the word and the term mechanosensitivity because this is what we actually do with peripheral nerves when we mechanically stress them in a way, may it be
okay.
palpation or compression, or may it be the idea of a stretching movement of tension, then we assess the sensitization of the tissue that is around our nerve cells. We call it epinorium, perinorium, all these sheaths around the nerve, because this tissue is also innervated, and every structure
Hmm.
that is innervated, actually with mainly sensory nerves, has the potential to be nociceptively active. Yeah. And this is
Okay.
actually what we are doing. We are not testing on length, really. We're not testing on the mobility. Yeah, it's a additional sign, but the real
Mm,
thing we are testing is the mechanosensitivity of neural soft tissue.
mm,
Yeah.
okay. Okay, I've got you. So what are you actually assessing when you're doing these tests? So, sorry, what are we treating when through that assessment?
The consequence of heightened mechanosensitivity leads us to maybe the idea of the desensitization of the mechanosensitivity. But we have to
Mm,
be aware that mechanical sensitivity is not only due to some mechanical issues like compression around a nerve or an inflammation or something, because the interesting thing is that mechanosensitivity also can be heightened through other stressful events in your life. So we are aware that a nerve test, like we know these upper limb tests, we know
mm,
straight leg raise, we know the slump tests, that these tests can be or show different signs and symptoms and results through a day, through different states of mood, they change. So we are aware that different components affect the mechanosensitivity and not only mechanical aspects. There are also mechanical aspects that affect mechanosensitivity, but we have to be aware that there are others. So it is always a sign for me, an additional sign, how sensitized a person might be in a broader sense as well. But um, in many cases, this gives me a hint to start with movement in a way.
yeah.
To start with the desensitization of affected movements. This is what my idea actually is. And actually, it is also, of course, a clinical state of the health situation of the nervous system.
Hmm.
How
Hmm.
healthy is the nervous system at the moment? This can be
Yeah.
affected because of an injury of the nerve, neuropathic pain situations, but also how is your neuroimmune system in at the moment? How can you see your neuroimmune system at the moment? This is something that also is in the background of my clinical reasoning.
Okay, that's really
Yeah,
helpful,
yeah,
and really interesting. So,
yeah.
so the traditional approach to neurodynamics has been about stretching nerves.
Yeah.
What have you found the limitations of that approach to be, and why are we needing to move beyond it?
Yeah, the limitation actually lies in the component of the nerve itself, because a nerve, regarding its structure, is not a structure that can be stretched like a muscle. Yeah, with
Mm,
uh, because muscles has fibers that are able to stretch and to elongate, and the nerve has the ability to elongate a little bit, but the real growth of length nerve can have in itself is maybe 8 to 10% of its own length. So this is not quite much. This is not that much. So there is a limitation in the idea of stretching a nerve structurally.
Mm-hmm.
And we have to think of the nervous system as a very mobile and a very adaptive system. Yeah, it adapts.
Yeah.
And the idea of a stretch, the idea of getting more length, of course, is some kind of adaptation, but the structures that adapt actually are joints, are muscles, is myofascial structures. And those also are limitations for a nerve to be stretched too much, because a nerve doesn't really like to be stretched long and hard, yeah, because we see it in many pathological situations like brachial plexus injuries, where there is a lot of stretch and
Mm.
what it leads to actually. Yeah, it, it needs a lot of power and a lot of force to rupture a nerve.
Mm.
The structures that are hurt or injured first are joints, muscles, tendons, etc. And then maybe a nerve really gets also stressed that much. But a nerve is a very adaptive and a very strong and a very yeah, capable structure. But it is not possible to elongate it like a
Mm.
muscle. Yeah. And I think this is one of the big limitations. The biomechanical studies, also from Alfred Brieg and also Sunderland and all these guys, did a lot of that. They showed there is a possibility that the nerve adapts also in length, but it is not comparable like a muscle that has this adaptation in being longer after some input. Yeah, it
Yeah.
adapts actually. And there is also a central nervous system that is very, very responsible for this adaptation of a stretching, of a stretching feeling, yeah, of
Mm.
how it feels to me, how I cope with this length of a structure.
Yeah.
Yeah,
Brilliant. That makes a lot of sense. Thank you.
yeah.
So you've recently started teaching the bodily relearning course. Um, how do neurodynamics fit into the broader framework of addressing bodily
Mm,
protection systems, not
yeah.
just the nervous system in isolation?
Yeah, I think maybe I mentioned it in the beginning a little bit that the mechanosensitivity that we test with our neurodynamic tests are one, on the one hand, a great big sign of the health situation of the nervous tissue, but also um, for me, they reflect the sensitivity of the person in a broader sense. Yeah.
Yeah, for
So
sure. Yeah.
if you're more stressed, your mechanosensitivity is heightened. And your mechanosensitivity, not also only your mechanosensitivity, also your sensitivity to light, to touch, yeah, which is mechanical, to noise is heightened. And I think as neurodynamics is uh, a core concept of movement therapists. And we are
Mm.
good in that. We are good in that to assess, and we are structurized and we are standardized. So it's a proper way of course, testing movement limitations and differentiation and symptoms, signs and symptoms provoking. But it is also a nice sign of how sensitized are you at the moment in your physiopsychological state. Yeah,
Yeah,
maybe also in
100%.
your psychoimmunological state. Yeah,
Yeah.
that's what I meant in the beginning, that it depends also on the state of the day, morning, evening, stressed, not stressed, relaxed, calm, hungry, thirsty, how
Yeah.
your output of mechanosensitivity tests actually is. And I think that's why we can use it also in a broader sense, and
Hmm.
also start for our patients that might be keen to movement and keen to desensitize it, and to start with easy, meaningful movements that include neurodynamic aspects. So this is
Yeah.
something that fits into this bodily relearning concept from Ben.
Yeah, I love how you're positioning neurodynamics as part of a bigger system.
Yeah,
And you talk about desensitizing structures
yeah,
whilst reconnecting patients to
yeah,
meaningful movement.
yeah,
So
yeah.
could you walk us through an example, a practical example of what that
Mm.
might look like in your clinic, please?
Um, in my clinic, it could when we think about people, yeah, I have a nice patient. She had big issues with pain in this field here and in this area,
Mm,
including the shoulder, including also face even. And it was very complex because we were thinking about, okay, is there something going on with her cranial nerves? And we checked that, and of course also all these red flag ideas. But a goal of her was to get back to tennis, yeah, to play tennis.
yeah.
She wanted to start it, and again, after some time, and she's quite a young person with about 42, 43 years old. And these structures here were sensitized through
Mm,
this ongoing long process, also this some kind of prediction of, okay, there's something wrong, yeah, and she was very alert in everything that happened here in this field. And next to the ideas of peripersonal space disorders, if you may call it like this, there were also ideas of how to move that. And a meaningful
mm,
movement for her was starting again with tennis. And so we also looked at movements that include um, uh, tennis movements. And like when we think about um, uh, median nerve, the median nerve has to be uh, capable of doing this movement. And
mhm,
we included actually easy median nerve movements into this idea of, okay, this whole area here, and then got back to tennis. And so she includes these easy movements to desensitize, to prepare, to maybe include also these predictive ideas of new way of bodily sensations, and
mhm,
into the final goal of playing tennis in a different context with different people with different um, times of the day. So from a very um, focused point of view to a broader point of view. And she is very happy now that she's has no pain at all during the tennis match. Yeah,
Interesting.
yeah, yeah.
Interesting. How long did that take, that process?
As she had a problem with this whole field here since at least 10, 15 years. It took me with her about half a year
Hmm.
to find also those meaningful situations.
Mm.
Because we
Okay.
think, okay, this is a nice movement. Yeah, we can do a nice exercise with that. But she does it because she's adherent. She's coping in therapy. She does what the therapist says,
Yeah.
but it has no broader meaning for her. And as soon as she told me, okay, what do you think about playing tennis? Yeah, I would like to do that. It got completely a different meaning, and a
Yeah. Yeah.
different meaning for her, and more value. Yeah, this is what
Hmm.
I appreciate. Then also, okay, let's include this, but the final uh, target or goal to achieve is to include it in a movement you like, yeah? And you
Yeah.
are in a different context then. So this is some kind of a graded exposure, graded
Mm.
activity approach we have here.
Yeah.
Yeah,
That's fascinating. Thank
yeah,
you.
yeah.
That really helps me to understand what you were talking about earlier.
Okay.
I can't lie, some of
Yeah,
it's quite
sometimes there
complicated.
are many ideas, and to focus it is not that
Yeah.
easy sometimes. Yeah,
No, that's great. Thank you. That's a
yeah.
really, really good example. So for clinicians, who are watching this and thinking they may already be using neurodynamics and we've just introduced this idea of through a bodily relearning
Mhm.
lens. What might looking at the same patient through a bodily relearning lens, how might that look different to if they were just looking at that through a pure neurodynamics lens?
Mhm. When I think neurodynamics themselves is it's not a concept. This is very important. Yeah,
Yeah.
it's an integrative part of our reasoning. It's an integrative part of our manual therapy thinking, of our physiotherapy, occupational therapy thinking, movement thinking, because we have the idea of neurodynamics is in every movement. Yeah.
Mm,
And
mm,
this is the first thing. So it always has to be included. Neurological testing, how does the nervous system work and how sensitive is it? Like we do it with every other structure. If we check
mm,
for a borsor in the shoulder, we test with some tests maybe how sensitive are these structures to mechanical input. And why does it not why not include it also for nerves? So this is something that is state. And
mm,
the idea of including it or the difference in I don't think it's a difference in the including it in the bodily relearning is it's a first way to get back to movement and to use these
okay.
everyday movements that have should work and should function to start with movement with the patients. Yeah, of course,
Mm,
you can say, okay, it's playful, it's some kind of distraction. It is. And I think this is a good idea that we use playful and distracting movements,
mm-hmm,
give the person a new idea of how movement might work. Yeah, because some people are so focused in it, okay, symptoms, no symptoms, symptoms, no symptoms. And this is again something they they um, they really are really waiting for it that the pain or that the symptom is coming. And with this approach in bodily relearning, we we have the movements, but in a different context. We
yeah,
use the same movements, but we shape it actually. We shape it for
yeah.
the patients.
Okay,
And
that's interesting.
this is, I think, one small part of the idea of neurodynamics in the bodily relearning courses. And it's nice movement experience. It's a new
Yeah,
movement experience. Yeah,
yeah.
with the old ideas also from David, do it in different contexts, do it in different situations, in different places, and do it in more meaningful places. Yeah, in your work. Yeah, if you're doing this movement at home, yeah, which includes some radial nerve movement. Maybe it's different than I'm using it in my workplace.
Mm,
Yeah, this is a
mm,
completely different meaning, and meaning shapes sensitivity, and meaning influences sensitivity, and then expectation gets changed. And I think this is something we can work on additionally to all the other approaches we use in physio. And
okay.
also to maybe step a little bit more away from these passive movements of
Yeah, yeah,
dynamics.
for
I think
sure.
this is people need some self-management as well. And I hardly do any. Maybe in the cranial facial field, I do it more because it's more difficult coordinatively. But
Mm,
in the other fields of the body, I stopped nearly with every patient to do it passively. Yeah. So
yeah,
it
yeah,
has
that's so
more makes more sense
interesting.
as an
That's so
active movement.
interesting. Yeah,
Yeah.
yeah. Just we didn't. This wasn't on our list of things to actually talk about, but just it just seems to fit in naturally here. So, what about the bodily relearning approach? Do
Yeah.
you, because you've just recently started teaching it, what do you find to be the thing that you like most
Yeah.
about it?
Mm. The integration of movement
Yeah.
and as a core concept of NOI, of course, we use the movement of nerves and neurodynamics. I think that fits
Mm-hmm.
perfectly also in our philosophy. And of course, we can get into a broad approach with other movement styles and training and all the sports therapy aspects. This is great. But I
Yeah,
think
yeah,
this
absolutely.
integration, but also the I think it's a perfect way to expand our ideas of explained pain. Because there is one
Oh,
thing, explained pain courses are great to start to understand, try to understand how pain might work,
mm,
yeah, as a physio, as a professional. And with this attitude and with this background, I think the bodily relearning courses provides a very nice way of, okay, how can we use this knowledge now um, with the patients. Yeah, with all these worksheets Ben provided and all these really, really nice approaches of, maybe you can call it protectometa. He calls it
yeah.
different. And I think it's great that he calls it differently because the wording is something that is very important for the patient. So we have new ways and start to create new ideas to provide this knowledge for our patients.
Mm,
Uh,
okay.
it is not the idea of the bodily relearning course to have a new philosophy of pain, and there are many ways now to think about it. Like if we think about the predictive brain, which is in my opinion, in my humble opinion, as far as I understand these ideas, also somehow included when we think about new movement, yeah, and
Mm,
new ideas of movement and new settings and approaches of movement. But this is not the main goal of this course. The main goal of this course is to use the knowledge we have to
yeah.
get really into to patient contact and to a direct approach and to a direct management approach. I think this is the strength of the course.
Yeah.
And
I agree.
yeah, and I think this is also what I got as a feedback from one group. Okay, this is biased, but they said, okay, many things make more sense now
Mm,
to really get into work with the patients, and they feel more confident than to work with the patients because I have the
yeah.
experience of many participants in the explain pain courses. They say, "Wow, this is great! It's great to know, but how?
But
What is
how
the
do I do
next
it?
step? How do I do it
Yeah.
then?" Yeah, and it's
Yeah.
not only about explaining. It's, I think, to know these things about pain we know now, if we can call it knowing or knowledge, is good for our attitude in the when we see and when we get into contact with our patients. But the real work and the management work is really hard, and I think bodily relearning in some parts provides that.
Yeah. I agree completely. I think that it's a missing piece of a puzzle, isn't it? It
Yeah,
is the
yeah,
how,
yeah,
uh, how you use your
yeah,
existing knowledge
yeah,
and overlay some of the explained pain stuff, but actually really practically how you take that into your
yeah.
clinic with your
And
patients.
it's not the why, and I think we can discuss a lot
Yeah,
about,
that's right. Yeah.
uh, but I think it's the how. And the
Yeah.
neurodynamic approach fits perfectly into this because this is something also we are good at, we
Yeah.
have experience with.
Absolutely.
Maybe in the way of seeing it, like I said before, see it more as a testing and treating of mechanosensitivity.
Hmm.
But mechanosensitivity is not only heightened or lowered through mechanical components, but
Mm.
also through neuroimmunological, endocrinological, day-to-day changing behavior of a person. This also influences mechanical
Yeah.
sensitivity. Yeah,
Yeah. Brilliant. Thank you, Bernard. Oh, God, it time's up.
like always,
I
goes so
don't know where the
fast.
time goes when we do these
Yeah,
sessions,
yeah,
but it's literally we're 30 minutes. We've end to end. We're done. So I just wanted to
right.
share with everybody the Bernhard does have a bodily relearning online course, which a lot of people have been asking for. You did an in-person one in Finland, but we've had people from all over the world asking for this course to be delivered online, and he is doing that in October, the 1st to the 3rd of October. And the details of that will be in the show notes, the link to just click through and check out what the learning outcomes are and what you can expect to take away from that course. So we have just scratched the surface here today. And if you want to deep dive with Bernhard, if you want to spend, I think, 3 5-hour sessions with you,
Yes.
then check that out because it is absolutely fantastic. You were absolutely buzzing after you did the one in Finland, and everybody we've got some amazing feedback about what people had experienced during those days with Bernhard. So just to wrap up now this session. If you were to say to people who are watching this, what would be your one key takeaway from what we have discussed this morning?
One very personal for me takeaway is the word mechanosensitivity.
Yeah.
Yeah. And mechanosensitivity is not only influenced by mechanical components like pressure or tension,
Mm,
but also think in a broader way, mechanosensitivity can be changed through emotions, daytime,
yeah.
your state of mood at the moment. And we are aware of that, but we should include it and integrate it more in our view of the patients and how we meet them. Yeah,
Thank
see
you.
them and meet them.
Thank you, Bernard. Thank you for joining me this morning. And thank you to
Thank
everybody
you.
for your attention and watching this Neugroup clinical discussion. We'll be back. Well, I'll be back with somebody in a couple of weeks' time, but Bernard will be doing some more of these sessions a little bit later on in the summer. So thanks for your time. Thanks, Bernard, and enjoy
Thank
the rest of
you.
your day. Take care.
Have a
Bye.
good day. Bye. Bye. Bye.
Cheers. Bye.